Yeah.
Yes. All right, welcome, everybody. Hi, welcome to SURG-Grand Rounds. I'm Kathy Van Leeuwen, Associate Surgeon in Chief, and what I call myself is Queen of the East and the West. It's sort of like a Wizard of Oz thing. So welcome. The CME code is up on the screen. It's going to be displayed several times throughout the talk. So go ahead and use that to claim your credit. And then, John, how do you want questions? They put them in the chat or by email?
Chat or the Q&A.
Okay, chat or Q&A for questions. So we're delighted that Dr. Jay Hauptman accepted our invitation to share his passion with you. Dr. Hauptman has recently joined us here at Phoenix Children's as the role of Division Chief of Pediatric Neurosurgical Surgery. He's also the Associate Director of the Barrow Neurologic Institute at Phoenix Children's. So he was born in New York. He studied psychology and biology double major. He went to Rutgers for medical school, and he was a member of AOA and all the things you need to do to become a neurosurgeon. He then did his training at UCLA. I went to USCJ. We should probably talk about that at some point. Yeah. And he took time out to obtain a PhD in neuroscience. He did his pediatric neurosurgery fellowship in Pittsburgh at Children's Hospital of Pittsburgh. So prior to joining us, Jay wore a lot of hats at the University of Washington and Seattle Children's. He was director of pediatric epilepsy program and the hydrocephalus program. He was involved in multiple complex care programs, has numerous publications. He was involved in many grant-funded studies, which he's continuing here as principal investigator. And he's devoted his time to training fellows and mentoring students. So he's really sort of a triple threat. He's a recipient of many scholarships and awards. He was named top doc in Seattle, and I'm sure he will be named top doc here as well. So far at Phoenix Children's, Jay's been a delight. He's very friendly. He's very eager to collaborate. He's been noticed by his colleagues for sure. He brought his family with him, obviously, to Phoenix, his wife, Susan, of 16 years, and his 3 kids, Cooper, Avery, and Marley. Hopefully they're enjoying the summer.
A little hot.
It's a little hot. You got to swim every day. He describes himself as an avid outdoorsman. So I'm sure he will include his future research plans with us today. We're lucky he came to Phoenix to join this very talented group of neurosurgeons that are already here. And so please give a warm Phoenix welcome to Dr. Hauptman.
All right, before we get started, I'm going to ask the trainees, I'm so sorry, can you stand up and stretch for me? Everyone up. Come on, everyone up. Everyone up. And I know, just a quick stretch, guys. And before you sit down, you're going to come up to the front. I got you up, didn't I? Come on, come on. Don't be shy. I brushed my teeth this morning. No, just to the front rows. I want you guys to sit up here. You can come to the front too if you want to hang out with me. All right. We're going to do this crazy thing where, like, I don't just talk at you, but you respond when I talk at you. Come on, everybody. Come on. Come on to the front. Look, we got all these seats here. Come on, come on. The faculty can stay in the back. They have an excuse. Have another couple of years, I can ask you to do stuff for me. All right. Oh, are you guys gonna hide in the back there? Come on, I'm a neurosurgeon. I'm not that scary. My kids might not agree. Come on, come on, come on. All right. While you are mobilized, I realize that everyone is coming here from a different background, so I'm going to try to keep it pretty high level. You know, pediatric neurosurgery in and of itself is a specialty which essentially just consists of doing the entire breadth and depth of neurosurgery for children. And as you all know, children have different neurological diseases compared to adults. One particular neurological affliction that is both relevant to adults and children is epilepsy. And so for a lot of years, I've actually done epilepsy surgery in both adults and children, but they are very different. Even though it's the same disease, the approaches are very, very different in children and adults for the reasons that I'm going to explain to you, but they're very pragmatic. And so what I'm going to talk to you about today is for the next, I don't know, 55 slides or so, epilepsy surgery in children. And my hope is that I'm going to take you through the entirety of the field so that when you leave here, you really understand why we're doing it And you'll see the relevance in your own practices, because everyone here has a part to play in finding these children and referring to us, and I'll explain why in a second. And so I have some disclosures. They're not particularly relevant to this one. And this is probably the most important slide that I'm going to show you. There are a lot of things that we do in neurosurgery that are truly interdisciplinary, and this is one. The neurosurgeon cannot identify the child, bring them through the entirety of the pre-surgical pipeline out to the other end, which is hopefully a successful epilepsy operation, without a ton of help, So intuitively, our pediatric neurologists are very, very important in this, because they do the majority of the workup. But we have neuropsychologists, we have our surgical staff, our anesthesiologists, our radiologists who are going to help us identify structural lesions on MRI and PET, our rehab doctors who have to take a lot of our kids through the postoperative chronic phase to where they can be as functional as they possibly can be, and then everyone else, our APPs, our EEG techs, our nurses, you guys, everyone in this room who has touched a patient who has had epilepsy surgery. Thank you. These are the objectives for the next 15 minutes or so. We're going to go through these. Interrupt me if you have a question. I have a mild form of adult ADD, so you need to say, hey, Jay, or dude, or that guy, or point at me, or cough really loudly, like a fake cough. I like that one. But you need to interrupt me, or I might miss you. Or I'm going to call on you. It's even worse. I mean, who wants to be called on? It's like 7:30 in the morning. All right. So how many of you personally know someone who has epilepsy? So those numbers are probably a little bit greater than the epidemiology of epilepsy itself. It affects between 1% and 3% of the population. It is a major disease. It's got an epidemiology similar to that of things like depression. Having a single seizure does not get you that diagnosis of epilepsy in your medical record. You guys know this. I know our pediatricians know this. How many febrile seizures have you guys seen in your training? Having a single provoked seizure, i.e. a febrile seizure, does not get you the diagnosis of epilepsy. What gets you the diagnosis of epilepsy? 2 unprovoked seizures. Seizures that don't have a reason to have occurred. Reflex seizures don't count. Febrile seizures don't count. Why 2? Why is that the magic number? Because if you've had 2 seizures, the chances of you having more are greater than 60 to 90%. It's actually quite intuitive. That's what gets you from having a seizure to having epilepsy. Does that make sense? 2 unprovoked seizures. Now, that doesn't get you to a neurosurgeon, that gets you to a neurologist. And I'll tell you what, for my pediatricians in the audience, there is a national shortage of pediatric neurologists, a substantial national shortage of pediatric neurologists. What does that mean? It means you guys are the pediatric neurologists for a lot of your patients with epilepsy. They are seeing you with greater frequency than they are seeing an epileptologist. Why? Because of access. You guys are on the front lines. So even though everything I'm about to describe to you may feel or seem esoteric, it is not. And every time you're seeing a child in your clinic who's got 3 anti-seizure medicines in their EMR that you may feel like you're not managing, you are. Because you are seeing them with greater frequency than they are seeing their neurologist. Where a surgeon gets a little more interested in epilepsy is in what we call medically refractory or treatment-resistant epilepsy. It's born out of a very specific definition. Years ago, I've quoted this study for like 20 years, so more than 20 years ago, there was a large study that occurred in Great Britain in which they took every single child who was diagnosed with epilepsy and just followed them. That's all they did. It was a natural history study. And what they found is that when a child is on 2 anti-seizure medicines, 2 anti-seizure, didn't matter which ones they were, could have been the oldest. Does anybody know what the oldest anti-seizure medicine is? Anybody know? is actually discovered by a namesake of mine, a Hauptman, not me, not where someone related to me. Hauptman, this particular Hauptman was at the time a resident meaning you lived in the institution where you trained in a sanitarium, in which they were using barbiturates in folks that were labeled as insane. And it turned out some of them had epilepsy, and it also turned out that it worked. And so barbiturates are actually our oldest drug, but it doesn't really matter if it's the oldest anti-seizure medicine or the newest. 2 anti-seizure medicines and you continue to seize, you are refractory. Why? Because if you're on 2 anti-seizure medicines appropriately dosed and tolerated, the chances of a 3rd or a 4th or a 7th or a 10th anti-seizure medicine rendering you seizure-free is less than 5%. There is a 95% chance if you are on 2 anti-seizure medicines, you will continue to seize, and it really doesn't matter what the newest drug the reps are bringing to your office, those cute little pens, cupcakes on the back table, these delicious turkey, bacon, avocado sandwiches for lunch. It really doesn't matter what that anti-seizure medicine is. If the child has a lesion on their MRI, a structural brain lesion that's causing the seizures, a low-grade glioma, a cortical dysplasia, which is a malformation of cortical development, or some other genetic anomaly, the chances are near 0 that they will be seizure-free on medicine alone. Where epilepsy surgeons get particularly excited about things is that we believe, and I hope I can show this to you in the next few slides, if we continue to just throw meds at these children, the results are unacceptable because those years of seizures are affecting the developing brain in a way that we cannot reverse. And they're also providing a substantial risk of morbidity and mortality that is physical, as in addition to cognitive. We know that when children have lesions on their MRI, like that one right there, that's a hippocampal lesion on the right side, that the likelihood of their being seizure-free is much lower than if they didn't have a brain MRI. That's a percent seizure-free than Kaplan-Meier. So again, just to hit this nail a little bit harder, the definition of treatment-resistant epilepsy is failure of 2 appropriately dosed and tolerated anti-seizure medicines to achieve seizure freedom. One question we get a lot is, what's seizure freedom? What does that mean to be free of epilepsy? It means not to have a seizure at least 3 times longer than your longest interseizure interval. That matters because we have some kids who seize once a year. So being seizure-free for a year is not seizure-free. Being seizure-free for 3 years is seizure-free. Does that make sense? So not every child seizes every day. 1 year minimum is what we consider to be the minimum number of days necessary to achieve seizure freedom. Treatment-resistant epilepsy is a really big problem in pediatrics. So we're going to talk about peds. The incidence of seizures in children new onset's about 4 in 1,000. That's a really high incidence. And over 2 years, about 10% of them will become medically refractory. An additional 8% will continue to become medically refractory over the course of a year or 2 of throwing meds at them. For a total of somewhere between 20 and 30% of children will become medically refractory over their childhood with epilepsy. That's a huge number. We're not seeing a third of those children in epilepsy surgery. So why a surgeon? Why do we choose brain surgery? Epilepsy for the longest time was thought to be a medical disease. It's like, why would the surgeons be interested in this? This is something we treat with medicine. And the hope is in the next few slides, I can show you why it matters and why it works. It turns out, and some of these are going to sound very intuitive. In children who have uncontrolled unilateral temporal lobe epilepsy, over 60% will have an IQ less than 80. Independent of the reason, epilepsy, intractable epilepsy is an independent risk factor for intellectual disability early in life. So if you have intractable epilepsy in the first 2 years of life, the likelihood of you having long-term intellectual disability is very high. We know that if seizures are not adequately controlled, there will be impairments in a wide spectrum of neurocognitive dysfunction, language, social skills, communication. Have any of you seen a child with what we call epileptic encephalopathy, a child who's had seizures their whole life, inadequately controlled? It looks a little bit like autism. They have that sort of cross-domain dysfunction, communication skills, social skills, and then they have the added deficit of a cognitive deficit. We also know that poor seizure control results in poor psychosocial outcomes, lower rates of high school completion, employment, marriage, starting school, finishing school, having a job, holding a job. It has massive, massive societal, long-term economic consequences. And the truth is, for the years that I took, so while I was at the UW, I was an epilepsy surgeon at the Children's Hospital. I was also an epilepsy surgeon at Harborview Medical Center. And Harborview, for those of you who are familiar with the Pacific Northwest, that is a very special place. And that is a state hospital for the entire Pacific Northwest. And so I would have folks coming in from Alaska and Idaho and Wyoming and Montana who were seeking epilepsy surgery as adults. And universally, when I would take care of a 30-year-old or a 40-year-old that had the epilepsy since they were a child, their greatest regret was not having it taken care of sooner. And their goals completely shifted. In children, our goal is to prevent all of this. In an adult, that ship has sailed. And so they come looking to get a driver's license, looking to get off disability, looking to get back to work, or looking to reduce this one thing we're going to talk about in a second called SUDEP risk. We know that early surgical intervention for intractable epilepsy results in less cognitive and intellectual disability. We know that. We know that we can stabilize neurodevelopmental indices, but perhaps the most compelling reason to do an epilepsy operation is to prevent children from dying of their epilepsy. I'm just gonna let that sink in for a second, because we don't really think of epilepsy, I think, in the sort of colloquial sense as a lethal disease. I am telling you, it is a lethal disease. And most of these children are not dying in the hospital. They are dying at home. Sudden unexplained death secondary to epilepsy, we abbreviate that as SUDEP, has a risk of 0.5 to 1% per year, and that is cumulative. If a child begins to have intractable epilepsy as an infant under the age of 1, by the time they are 10 years old, they carry a 10% risk of mortality. By the time they're ready to go to college, they carry a 20% risk of mortality. Tell me a childhood disease that is common, as common as epilepsy, outside of the cancers and blood disorders, that carries a mortality risk of 20% in 20 years. And I think this is perhaps the easiest case to be made for epilepsy surgery, because that SUDEP risk goes to 0 if they are seizure-free. You can change a teenager's trajectory from a 12 to 15% mortality risk over the course of the year to 0. And I think that is compelling. And when I'm having conversations with families in the office about whether or not to have their child have an epilepsy operation, that is the easiest calculation to make. I will also tell you that there is no surgical risk that approaches anywhere near the SUDEP risk. At most, 1%, 2% risk of the really scary stuff from brain surgery. Within a year or two, that SUDEP risk just blasts that right by. And I used to take care of a lot of folk up in Washington State whose parents worked for Google and Facebook and Amazon, engineers, computer scientists. And when I was making the case for an epilepsy operation, they found that to be the easiest calculus, SUDEP risk. So again, if you leave today recognizing that medically intractable epilepsy, and you guys are probably taking care of a lot of children, everyone everyone here, from my pediatricians to my general surgeons, how many kids are you seeing come through the OR that have anti-seizure medicines on their roster? That may not be the issue you're taking care of, but you actually are, because you're taking care of a child that has a much higher mortality risk than all the other children that you're taking care of. We know that if you do medical therapy alone versus epilepsy surgery, children do not live as long. This is my buddy Sandy Lamb. She published this pretty recently. This red line here is a Kaplan-Meier survival curve for children who have epilepsy on medical therapy alone. This is a Kaplan-Meier curve for children who get a palliative epilepsy operation. How many of you heard of VNS, vagus nerve stimulation? That's this. This is a Kaplan-Meier survival curve for kids that get cranial epilepsy surgery. Look at that difference. It's a 25% reduction in survival with medical therapy alone versus having an epilepsy operation with an intensive care. Very compelling. We can do a lot better though. This is a survey I've been showing for over a decade. This was a survey for epilepsy surgery centers. And what you see here on the left, these are children that were referred for epilepsy surgery. This is how old they were when they started seizing. 46% started seizing in the first year of life, an additional 14% in the second, and it kind of tapers off. This is the age they were when they were referred for epilepsy surgery. They should look the same, but they look opposite. Why? Because it's taking us 10 to 14 years to identify these children who started seizing in the first year of life as being candidates for epilepsy surgery. And so the vast majority of them are presenting in 17, 18 years old. So there's a lot of room to improve here. And again, I will make the case that everyone in this room are going to be the people who are going to help us fix this. Because you guys are seeing these patients more than their epileptologists, and surely more than me. I'm not seeing them at all. And so again, I'm going to sound like a broken record, but if you have a child who is still seizing on 2 anti-seizure medicines, they need to see somebody, because we can do better. I'm going to say that a couple times today. Hopefully you leave with that. We'll do a little fun review of the pathophysiology of epilepsy. We see a lot of different things in epilepsy surgery. By far and away, the most common thing, and this is what I have spent my entire career studying, is cortical dysplasia. Cortical dysplasia is not a tumor. It is a congenital malformation of cortical development, hence a dysplasia. Thank you. Okay. So cortical dysplasia, also known as malformations of cortical development, they're not tumors. They don't grow. Okay. They are essentially a collection of neurons that lost their way during embryological development. They wound up in the wrong spot, they're misoriented, and some of them are stuck in abnormal developmental states. You could think of it almost like a hamartoma, though it's not quite a hamartoma. This, by far and away, is the most common etiology that we see in epilepsy surgery in children, and also has both the best and the most mixed results from epilepsy surgery. I'll get into that in a second. About half of children with cortical dysplasia will have something on their MRI, but sometimes it is ultrastructurally so inconspicuous that an MRI will be negative, and only histologically will they be positive. PET scans are something we use a lot of in this group, and PET scans can actually be very helpful in up to 90% of cases. Does anybody know what we look for in a PET scan in epilepsy? I'm just curious. Do you expect, I'm going to ask it a different way. Do you expect a child who you bring in through the epilepsy surgery pipeline, they're not seizing right now, you do a PET scan. Do you expect an area causing epilepsy to be hot or to be cold? Let's take a vote. So they're not seizing, They're just kind of hanging out, getting their test. How many of you think an epilepsy hotspot's going to be hot on PET? How many of you think it's going to be cold on PET? How many of you need more coffee? Okay. The vast majority of you are right. It's going to be cold on PET. It's going to be interictally hypometabolic, and it's very helpful. Focal cortical dysplasia is very common in the frontal and temporal lobes, though I'm going to show you cases where it involves the entire hemisphere. Sometimes we've got to remove the entire hemisphere. We have a classification for focal cortical dysplasia. It turns out they're not really they're histologically graded in terms of severity, but ironically, the surgical outcomes for the more severe type are better than they are for the less severe type 1. And those have to do with really how conspicuous the histology is. If you look at an MRI of a child with focal cortical dysplasia type 2, you can see the lesion. It's going to look different. For type 1, sometimes it's so subtle you won't even see anything on the MRI, and they're actually the most challenging to treat because typically their lesions are way more widespread than what the MRI will suggest. We see a lot of low-grade glial tumors in children with intractable epilepsy, gangliogliomas, DNETs. They can be associated with cortical dysplasia. This is an example of a DNET here, a low-grade glioma here in the occipital lobe. And they do really well with surgery. Over 80% of the time, you can cure their epilepsy by just removing the tumor. Other things that we see, perinatal infarcts, infections. Interestingly, mesial temporal lobe sclerosis, which is a scarring of the hippocampus, is the most common reason why an adult gets epilepsy surgery and one of the least common reasons why a child gets epilepsy surgery. So we see it, but not that frequently. Then we start seeing the more uncommon, but I've seen a lot of these over the years because I see a lot of things that are uncommon, genetic causes of intractable epilepsy. I've taken care of probably a half dozen or more Sturge-Weber kids. How many of you have seen Sturge-Weber? It's a pretty remarkably, phenotypically typical disease. They have a port wine stain that's in the V1 distribution, the trigeminal nerve. A lot of them have intractable epilepsy, and it ultimately results terribly in hemiparesis because they'll get essentially a very large angioma. It's almost like a small arterial venous malformation, it's a PL angioma over the entire hemisphere. And over time, that causes dystrophic calcification of the sensory motor region that leads to contralateral hemiparesis. I've done hemisterectomies on these children and very large-scale temporal parietal occipital disconnections, and they do incredibly well. A lot of surgeons get a little nervous about doing it in these kids because you're essentially disconnecting a hemispheric arterial venous malformation. And so there's some surgical considerations in this that can make people a little worried, but it's a very safe surgery to do. It can be done well with great outcomes. I've seen a lot of tuberous sclerosis in my career. How many of you taken care of kids with TS? I would quiz you on the chromosomes, but I don't want to torture you, so I put them up here. 9 and 16 are the two chromosomes. This is arguably the syndrome of epilepsy we know genetically the most about, yet we still don't understand it. Because the majority of kids with TS are not germline TSC mutations. They're mosaics. And so we have a really hard time understanding both the inheritance of this disease. We understand it is autosomal dominant, but it's not quite that straightforward, and the very mixed phenotype that these kids will have. I'm sure of all the kids with TS you've seen, no two kids are exactly the same. There's an incredible amount of phenotypic heterogeneity there. And we still don't really understand where the epilepsy comes from here. Is it the tuber? Is it the gliotic tissue around the tuber? And having resected a lot of tubers over the course of the last 10 years, I'm not sure I can answer that question for you. We just don't know. One particularly uncommon disease that we'll see once or twice a year in Seattle. I think we'll probably see a similar number here, something called Rasmussen's encephalitis. This is an autoimmune encephalitis that only affects one hemisphere. That one hemisphere starts to shrink over time. And these kids, usually by the time they're teenagers, now have hemiparesis and intractable epilepsy. We'll take these kids, admit them, we'll put them on IgG or steroids. It's all temporizing. Hemisterectomy, which is the most dramatic surgery that we do as epilepsy surgeons, is the only real cure here. And it is dramatic. You'll have kids that are seizing 100 times a day who will be seizure-free after a hemisterectomy. Angus Wilfong, who's my partner in neurology and the chief in neurology here, is a world expert in hypothalamic hamartomas. How many of you have heard of hypothalamic hamartomas? Does anybody know what, there's something very unique about the seizures that kids with HHs get. Does anybody know what it is? What kind of seizure they get? I can tell you what it's called. It's called a gelastic seizure. Does anybody know what a gelastic seizure looks like? It's unforgettable if you've ever seen it. Did I put it up there? I did. Have you seen one before though? Has anybody seen one? You have. Tell me, describe it to me. What's so unique about it? It's zero happy. It's mirthless. My first year in practice, this is before I was at the UW, I was in LA at the time. I had a teenager who had undiagnosed hypothalamic hamartoma and gelastic epilepsy. He was a brilliant young man, and he was a football player. And he described to me that he was able to suppress the gelastic seizures by kind of hiccuping. And so the laughter was he would kind of, and then he would suppress the gelastic seizure. He did that for 15 years. Kids with gelastic epilepsy, when you watch them laugh, it is the most unusual laugh you will ever see in your life because it's laughter without joy. Most kids with hypothalamic hamartomas hate it, and they hate the feeling. And it's your body is making you do something that has a very significant social consequence. Laughter means joy, but they don't feel good while they're doing it. They don't have that euphoria. And so it tortures them. Kids with hypothalamic hamartomas can also have hypothalamic dysfunction. Some of them can get very, very angry. We call those rage attacks. And that's actually the biggest problem that parents have with kids with hypothalamic hamartomas. And then some of them can have things like precocious puberty. Angus and with Angus, we do a lot of laser ablations for these kids. This is a dramatically improved operation. It used to be you did this open surgery to go down to the center of the brain and resect these lesions. And you can see it's a very far reach from up here. Now we stick laser probes in them using a robot, heat them up in MRI, and have amazing outcomes. And they go home the next day. It's a dramatically different operation it used to be. One of the other things that I've spent a lot of time thinking about and treating is something called hemimegalencephaly. That is the most severe form of cortical dysplasia in which the entire hemisphere is one giant cortical dysplasia malformation. And those kids require hemisterectomy for seizure control. Getting back to it's a team sport. When a child is diagnosed with intractable epilepsy, they're referred to a comprehensive epilepsy surgery program like the one we have here. There we enter what's called the pipeline. And the pipeline is a battery of tests that need to occur in all children who have medically intractable epilepsy to determine A, are they a surgical candidate? And B, what is the right type of surgery for them? It consists of doing scalp EEG, sometimes even invasive brain recordings, a bunch of MRIs, including structural and functional, and then a neuropsychological evaluation so that we can understand where are there areas of neurocognitive deficit, because we want to protect and improve those areas. Video EEG, you guys have all seen it. We admit these kids for up to a week It's torture for the parents because they need to take a week off of work and they need to sit by their child's bedside and keep them occupied while they're in the hospital for a week. And we try to capture as many seizures as we can non-invasively. Like I said, we do a neuropsych evaluation and we assess a variety of domains because, as you could imagine, if a child has frontal lobe dysfunction, that can clue us into the frontal lobe potentially being the area of concern for their epilepsy. We do a lot of high resolution MRI, and this is just highlighting some of the various pathologies that we see. Though I will tell you, over half of the kids that we see have completely stone cold normal MRIs. So that's not always going to tell us where do we do the operation. We do PET scans. We talked about how sometimes if you do a PET scan while a child is seizing, the area will be hot. But if you do it in between seizures, it's interictally colder than the opposite side. This is just an example of an area on MRI that looks pretty normal, but on PET scan does not. And that can help us clue into where we want to reset. SPECT scan is where you inject a radionuclide in a child as they're having a seizure, and it can light up the ictal area. And then there are a variety of surgical approaches, which we'll get into in a second. When I'm describing the surgical workup for epilepsy, I describe it as this movie, My Cousin Vinny. How many of you, I'm older than you guys, but how many of you have seen My Cousin Vinny starring Joe Pesci? Please tell me at least half of you. Come on, man, it's not that old. Oh my God. I show my kids like Star Wars and they hate it. They're like, it's old. I don't, you know, the special effects are terrible. And they like the new Star Wars with Jar Jar Binks, which is terrible. That's a terrible Star Wars, you know? Anyway, yeah, the only Han Solo is 70s Harrison Ford Han Solo. That's it. Or 80s Harrison Ford Han Solo. Not 90s and 2000s Harrison Ford Han Solo. Finding the area where the seizures are coming from is no different than Joe Pesci defending his cousin in My Cousin Vinny. Now, you may recall from that movie, Ralph Macchio, the Karate Kid, and his buddy were driving through the Deep South. They were in the wrong place at the wrong time. They exited the convenience store right as someone came in to rob and shoot the convenience store clerk. And then they were arrested and tried for it. And in order for Joe Pesci ultimately to exonerate them, he presented a whole host of circumstantial evidence. They didn't have like a video camera of the person committing the crime. There were no DNA fingerprints. So they used a lot of circumstantial evidence. And one of the classic parts is when Marissa Tomei, Joe Pesci's girlfriend, is talking about tire tracks in the mud, and then there's boot prints, and there's an eyewitness through a dirty screen with eyeglasses, and that's actually how you figure out where epilepsy is coming from. There is no one test that you can do that says it's coming from right here. That test does not exist. So you end up using MRIs and PET scans and DTI and SPECT scans and video EEG and invasive neuromonitoring to try to localize where the seizures are coming from. Because the closer we can get, the more likely we can offer a brain removal or resection and then attempt at cure. Why do we want to cure these kids? Because the SUDEP risk is 1% per year. That's right, 1% per year. It's worth it. These are all the surgeries that we do. Stereoelectroencephalography, which is something I started doing over like the last 7 or 8 years. That's when it started to become popular again. We use this robot. It's robot-assisted surgery. It's a robotic arm that allows us in 3-dimensional space to place an electrode within sub-millimetric accuracy, okay, to brain regions of interest. It's super cute. You don't shave the hair. These kids have minimal postoperative recovery. And when you're done, you just pull these out and they go home. They can go home that day. This is the old way of doing it, but I say old way in that I just did this last week. Subdural grid electrodes are where you do it. I'm sorry for the graphic photos. It's 8/11. It's fine. You guys have been awake for like come on. This is where you place coated electrodes on the brain surface and you leave them there. So you open up, you place them on the surface, you leave them there, and then you bring them to the epilepsy monitoring unit and record their seizures. while the wires are coming out of their scalp. Sometimes we'll remove the temporal lobe. This is an example of a temporal lobectomy. This is actually the best studied epilepsy surgery. This resulted in a very landmark publication in New England Journal of Medicine now over a decade ago, showing that surgical therapy is far superior to medical therapy when it came to temporal lobectomy. This is an adult paper. Sometimes we'll remove things outside the temporal lobe. This is actually a cavernous malformation. Does anybody, I'm going to give you a hint. This is the left frontal lobe. Does anybody know what eloquent region is right here? Left frontal. What eloquent brain region is in the left frontal lobe? I heard it. Yeah, Broca's area. Broca's area. Broca's area, if disrupted, will cause an expressive aphasia. It is absolutely debilitating. It means you cannot produce words. You want to, you understand speech, but you can't actually produce the word. They'll either come out with something that sounds very disarticulated or nothing at all. And so this was a cavernous malformation we took out of the left frontal lobe that required an awake surgery with mapping. Awake surgery is probably the most Hollywood of things that we do in neurosurgery. It's also probably one of the least common things that we do. For a long time, people weren't doing it in children. We do it in children now. This was a case that got some popularity from a few years ago of a girl who had a tumor in her auditory cortex, what we call Heschel's gyrus, and she was an aspiring Broadway performer. And so we removed the tumor with her awake and singing. And Seattle Children's elected to videotape this surgery. And it, what do the kids say nowadays? It went viral, something like 10 million views in like 5 days. And a story I can tell someone tell you guys at a later time of the Today Show and Rockefeller Center. But that's a very dramatic surgery that we do. Laser surgery is the thing that probably is the newest addition to the armamentarium. What we do is we place a laser cannula in a deep brain region. We bring these kids to MRI, and then using essentially what is a calculation on a phase contrast MRI, we are able to heat up in real time brain structures and ablate them. And when you're done, you pull out the probe and they go home in a day or two. No shaving of the hair, no big craniotomy, no blood, minimal blood loss, 5 cc's of blood loss. It's a very cute surgery, and it's very effective. This is an example of a hippocampal ablation. This is an example of a hypothalamic hamartoma, like the one I was describing to you earlier, in a child with gelastic epilepsy. I took these from a few years ago. The most dramatic surgery by far that we do is hemispherectomy. How many of you have heard of hemispherectomy for epilepsy? So probably about a dozen a year. I was doing, I probably will continue to do here. The indications are catastrophic hemispheric epilepsy. There are a lot of ways of doing it. It's a big operation. It takes me about 6 or 7 hours to do. And I would argue, though my partners may disagree, that it's the most technical surgery that we do in neurosurgery. It used to be that we physically remove the entire hemisphere. Now we do something called a functional hemispherectomy, which is essentially where you disconnect the 6 major white matter tracts that connect one hemisphere to the other into the brain stem. The corona radiata, the insula, the mesiotemporal structures, the corpus callosum, the basal frontal lobe and things. And happy to talk more about that if you have questions. But again, it requires smaller amount of brain resection, but a lot of technical manipulation of anatomic structures. You kind of have to know where they are. Corpus callosotomy has been around for a very long time, since the 50s. We still do it. We used to do it open through an interhemispheric approach. Now we do it with the laser. We can do a really nice job with the laser. This is what the laser looks like. You stick it in the corpus callosum, you ablate it. It works really well for a form of seizures called the drop attack. For those of you who've never seen a drop attack, like a gelastic seizure, it's a very dramatic seizure. It's instantaneous, catastrophic loss of all tone in your body. So imagine what that causes. So you're standing, and you all of a sudden lose all tone. What do you think is going to happen? And so a lot of these kids with atonic epilepsy, you guys see in the trauma service in the back row, because they come in with craniofacial injuries, they're losing teeth, they're having large scalp lacerations, and about once every other year, we'll get a kid with a big subdural. So it is it's a terrible disease. Calisotomy can cure a lot of kids with atonic seizures. It has a 70+% success rate. And a lot of those kids already have superimposed encephalopathy or Lennox-Gastaut. The newest technique in non-ablative epilepsy surgery is what we call neuromodulation, something I've been thinking a lot about over the last, I'd say, 3 or 4 years. VNS is the oldest of them all. This has been around for 20 years. This is a non-brain surgery. An incision on the neck, we wrap a coil around the vagus nerve, largest nerve that exits the brain, goes to the majority of the body. Intermittent stimulation of the vagus nerve can reduce seizures by about 50%. This is what it looks like. It's an outpatient surgery. Takes about an hour and a half to do this, home the same day. It's a beautiful surgery where it's one of the few excuses that we have anymore for cutting down on the carotid and finding the vagus nerve and wrapping this coil lead around it. And kids do great after this surgery. It's like I said, it's an outpatient surgery. How many of you heard of deep brain stimulation, what we call the brain pacemaker? Deep brain stimulation has been around for 20+ years for Parkinsonism. We've repurposed it in the last decade for epilepsy, and I'd say in the last 4 or 5 years in children. It is still off-label. I'm doing it a lot, but it's off-label. And what we're doing for deep brain stimulation is we're sticking it in an area called the thalamus. There are a bunch of thalamic nuclei that have been or are being studied ongoing. The one in adults is the anterior nucleus of the thalamus, and that was studied in 2011 with a large clinical trial. In children, we're actually using the central median thalamus and the pulvinar thalamus. And those seem to be very effective for reducing seizure burden in kids, 50 to 60+% reduction in all seizure types. Responsive neurostimulation, I'm actually about to do this in about a half an hour. This is a newer technology. It's been around since about 2015 in adults. I think 2014, someone's when I did my first one. And we are now using this in children. Again, it is off-label in children, but we are doing it. It's cool. It's called closed loop neurostimulation. So this actually is an implanted generator that has a computer inside of it. That computer is reading electrical signals from 2 implanted wires. So it's reading electrocorticography, and it will stimulate in response to a seizure. So we can program it to recognize what a seizure looks like electrocortographically, and then we can stimulate. I know it sounds funny using electricity on electricity, but it will reduce seizures by about 60+%, all the way up to 80 to 90% long-term 7 to 8 years later. And this is what it looks like. This is the device. We actually put the device inside the skull. This is just a table showing you that everything I just described seems to work pretty well. And I want you to focus on this right here. Even if we can't cure the epilepsy, so brain removals, brain resection, those are swinging for the fences. Goal 0 seizures. Neuromodulation will not cure. It will reduce, but it will also reduce the SUDEP risk. And so it's worth it, because the SUDEP risk is 1% per year, cumulative. So everything is about reducing the SUDEP risk. It also just so happens to improve quality of life, feelings of self-worth, school completion rates, all, job attainment, performance, all those things. These surgeries work. If we're doing a brain resection, we can get up to 65 to 80% of kids seizure-free. These are kids seizing 100 times a day. We can get them seizure-free. Some are seizing once a month. We can get them seizure-free. And up to 50%, we can get off their meds entirely. We know that the more widespread the seizure is, the lower the rates of seizure remission. And we know that when the MRI is negative, it's a lot harder to get these kids seizure free. The risk of any surgery that we offer is less than 2%. That is 2 years of SUDEP risk. There is no, even the biggest surgery I do, even a hemisterectomy, has a less than 2% risk of unintended neurological morbidity or mortality. In general, the risks of any surgery we do for epilepsy are far less than the natural history of the disease itself. We know that following surgery, these kids accelerate developmentally. And that's the key. That's the difference between children and adults. Adults are fully neurologically developed, most of them. Me, arguably, maybe not, but most are. And children are a work in progress. And if we can halt the seizures, we can make their brains function better. We can help improve their activities of daily living, reduce levels of caregiver assistance, improve behavior, attention, IQ, school performance, social adaptation. All these have been rigorously studied. One of the coolest studies is they took kids who had temporal lobe epilepsy, did a surgery and compared them to age-matched cohorts. And within 3 years, their quality of life indices of the surgical cohort normalized to children who didn't have epilepsy, children who never had surgery. That's a really compelling piece of data. They have greater feelings of self-worth, greater feelings of social competence. It also allows other members of the family to get back to work and school. And that's a big deal for our families who are taking care of children with epilepsy. I'm going to take a quick pause. I want to take a deep breath. I just threw a lot of stuff at you. Namaste. Okay. I want to talk about something completely different for the next 5 minutes. One of my research interests and one of the things I've been working on for about 8 years. My PhD was spent studying tuberous sclerosis. And there's an enzyme in this genetic pathway that tuberous sclerosis affects called mTOR. Has anybody heard of mTOR, mammalian targeted rapamycin? Yeah, it's a pretty famous enzyme nowadays. Say more than a decade, I think it was like 15 years ago. It wasn't quite as famous. It's in a lot of disease states, but it just so happens that when we were resecting tissue from children with intractable epilepsy, we were finding a lot of mutations in this pathway. When I came to Seattle, I was sitting in the office with my chairman, Rich Ellenbogen, who those of you who come to the Art Kaplan lecture, we've invited him to come and speak. He's an incredible human. I hope you get a chance to meet him. And then my other partner and mentor, Jeff Ogeman, who's now the chief medical officer at Seattle Children's. I was sitting in their office and they were like, all right, Jay, what are you going to do with your life? What are you going to do with your career? I'm like, oh, I want to be an epilepsy surgeon. They're like, oh, that's great. But like, what do you want to do academically? And I was like, oh, I was thinking, just continue working on patient-oriented outcomes and biomarkers of disease. And they were like, dude, we read your PhD thesis, and they didn't read it. No one reads the PhD thesis. I knew they read the abstract, maybe. You studied mTOR. Why don't you just try doing this in patients? Now, as a PhD, I was like, well, that's insane. Like, you don't just take something in the lab and start doing it to patients. There's a lot of stuff that happens in between. And they're like, yeah, we know. But why don't you just try to figure that out? And my head exploded because I never thought about what real bench to bedside would look like in my career. Because I always thought that chasm between what you do in the lab and what you do at the bedside is just so great. Very few scientists bridge that gap. They usually stay on one side or the other. They do real translational, or they do basic science, but very uncommonly bring something in the lab that they worked on in the lab and then try it on a patient. So they sent me to school. So I went back to the UW at night and I got a little degree in clinical trial design and implementation. And that was 8 years ago. And we started doing it. So this study, we called, you really try to come up with creative names for clinical trials and they never land. They just never hit that hard. This one was called Racer, and it was trying an mTOR inhibitor. This was a proprietary one designed by a company, but you guys have all heard of mTOR inhibitors. How many of you have heard of rapamycin? It's been around forever. It was used in transplantation. It was originally indicated for renal cell carcinoma, believe it or not, but it's a chemotherapy. Another famous one is everolimus, which is used in tuberous sclerosis. Anyway, so we took kids that failed epilepsy surgery. These were the hardest children to treat. They had terrible epilepsy. They went through epilepsy surgery. It was unsuccessful. They're still seizing. They are literally at the end of their rope. There are no options for them. So we took these kids and we enrolled them in a phase 1 clinical trial in which we did a dose escalation paradigm, trying this mTOR inhibitor. And the FDA only allowed me to do it for a month because they're like, you want to do what? That's kind of crazy. It's a chemotherapy. You want to use it in kids with epilepsy? I don't know. You can do it for a month. And I draw your attention to these two kids right here. P04 is a child that we later found out had a mutation, a constitutional mutation in AKT, which is upstream of mTOR. She was having approximately 100 seizures a day. She had a hemispherectomy and failed it. She had a hemispherectomy and failed it because her AKT mutation was in the good hemisphere too. And that was not known at the time of her initial surgery. And she went from having 100 seizures a day to 0 on drug. Then they started to come back. Her data and the data of a couple other patients like P05 was so compelling that I petitioned the FDA to let me open an open label. And P05 and P06 have been on drug now for 5 years, maybe. And P06 also went from having close to 50 to 100 seizures a day. This child has been seizure-free on drug. This is a child that failed everything: epilepsy surgery, neuromodulation, you name it. So there's something here. And this is what we're working on, we'll continue to work on. And this is actually what I would posit to be the future of treating epilepsy, is molecular targeting, because it turns out greater than 50 to 70% of kids who undergo epilepsy surgery have a mutation. It's usually a mosaic mutation, very, very hard to detect. We actually have to pick it up from the brain tissue itself. So I think that this is the future, and I condensed like 8 years of work into 2 slides, so forgive me. So I'll stop there because I got like 2 minutes or 3. You guys want to ask any questions? And then here's the CME code. And I'm happy to field any curiosity from you guys. Did I stun you? Did I just blow you away? Yes. If a child has failed 2 anti-seizure medicines, the likelihood of anything other than surgery providing meaningful benefit is less than 5%. So anyone who is literally just on 2 anti-seizure medicines, appropriately dosed and tolerated, their prognosis from an epilepsy standpoint is far worse without surgery than it is with. And so that's where you flip the switch and ideally identify those patients. But like I was showing, I can't bring it all the way back, but we still have a huge gap in identifying those patients and bringing the surgery. We're only scratching the surface. I think we're only seeing less than 10% of kids with refractory epilepsy who are coming to epilepsy surgery. Why? Because we have a nationwide shortage of neurologists, which is where our pediatricians are going to be so important here. We have access to care issues. I mean, here in Phoenix, like how many parents do we have who can take a day off of work to go see their neurologist, let alone to have their kid have an epilepsy evaluation, or even get a ride to the hospital? In the Pacific Northwest, we had a geographic barrier. I was taking care of kids from the Arctic Circle, from Barrow, Alaska, which is one of the furthest reaches of the United States, or Wyoming, or what have you, in the mountains of Wyoming. And so there's a lot of barriers that we need to address. There's cultural barriers. There are communities where epilepsy is felt to be psychological or psychiatric. There are reluctance to even get a diagnosis. There's, I mean, there are parts of, as you guys all know, there are parts of our country where there's not reliable running water, let alone access to comprehensive epilepsy care. You know, we spent a lot of time working with our colleagues living on the Native American reservations because we just want to get those kids to be seen in the hospital. And it was a tremendous lift to do that, to the point where we wanted to bring it to them. And so there's just a lot of work that needs to be done here. Yeah.
What are the sensory motor and personality postoperative ramifications of this, right?
So I'm going to describe it to you, but next hemisterectomy I want you to come and see the patient, because it's the only way you're going to believe what I'm about to tell you. If you do a hemisterectomy on a young child under the age of 12, they will likely immediately postoperatively be hemiplegic, okay? Within a year, they will be able to throw a ball, catch a ball, and run down the hallway. What do you think that is?
Is there gradual plasticity?
That's right.
Because of their age?
That's right. Age-dependent neuroplasticity. A lot of studies have been done on this. I call it baby magic. That's what I call it. The younger you do it, the faster the recovery. I've done hemisterectomy on 30-day-olds. They will start moving their contralateral extremities within 2 weeks. Most older children will start returning function proximal to distal. Over the course of the first month, they'll be able to start moving their shoulder a little bit. And then the rest kind of comes over the course of about a year. It becomes asymptotic at about a year. The things that are hardest to come back are the fingers, the toes, and the ankles. So you'll see a lot of kids who wear AFOs, and they'll need Botox in their hand to prevent contracture. And that's the price of a hemisterectomy in an older child. But to blow your mind even more, you can do a hemisterectomy on the dominant hemisphere, and their language will return. Can't do it in a 16-year-old. That probably will not happen. So we wouldn't offer that. But in a 5-year-old in a language dominant hemisphere, their language will return. And if anything, the epilepsy is decimating their language anyway. So the natural history is quite poor. From a personality standpoint, it's so muddy, because the anti-seizure medicines, I say this all the time, it's like hitting a finishing nail with a 12-pound sledgehammer. Anti-seizure medicines don't discriminate between malfunctioning and normal functioning neurons. They're all channelopathic agents. They work on sodium channels, for instance. They don't discriminate between abnormal and normal sodium channels. So these ASMs, they have terrible side effects. And if you talk to parents with kids who are on multiple ASMs, what will they tell you? My kid is impulsive and moody and wants to sleep all the time and can't keep him out of the pantry, or I can't get him to eat, or his weight is fluctuating constantly, or he's angry all the time. And so these are all side effects of the meds. So 50% of children who undergo successful epilepsy surgery can be taken off their meds entirely. So I would posit to you that for the first time in that child's life, their parents can actually see their child's personality off meds. The other thing I say a lot of is that, the epilepsy is a cruel disease. Imagine your child, everything that is your child is a giant boulder, a boulder the size of this room, And epilepsy is a little pickaxe. It's like one of those little pickaxes. Like I remember, like in the Shawshank Redemption, Tim Robbins' character has a little pickaxe he's creating little chess pieces on. It's like that size of a pickaxe. And that pickaxe is hammering at that boulder every day. So you look at that boulder every day, you walk past that boulder on the way to and from work, and it looks the same size. You take a picture of it one day on your camera phone, and then 2 years later, you look at it again, and all of a sudden that boulder is the same size. It's no different than me. I look at myself in the mirror. I still think I'm in my 20s. I am not in my 20s. My right knee reminds me I am not in my 20s. But if I look in the mirror every day, I don't see myself aging. But then I look at old pictures of me on Facebook and I'm like, what happened? I don't know.
I think so much of that too, because of basic science. There, it seems difficult to develop molecules that target different kids, but you can develop antibodies. So what's the state of antibody therapy?
That's a great question. So there is no state. Okay, and the short answer is there is none. I think the current state of the science is really revolving around repurposing existing FDA labeled agents that are molecular targets. And I think I think you're right. So antibodies are going to be a piece of this. And I think multimodality therapy, which is probably what you're thinking about too, is the future. Because the other problem is nature is smarter than we are. 2.5 million years of human evolution has shown us that we just can't outsmart our own bodies. And so, for instance, in mTOR, if you take an mTOR inhibitor and you crush mTOR complex 1, which is one of the downstream protein complexes, there's a responsive upregulation of mTOR complex 2, plus probably about 3 or 4 or 5 upstream positive and negative feedback loops that we're just reinforcing. And so and it's the same reason I think that cancer chemotherapy, it suffers the same problem, which is how do we outsmart the 10 different redundant mechanisms that nature has developed over 2.5 million years that prevent us from doing this to ourselves, And so I think the future state is going to be multimodality therapy, and it may require multiple approaches, both from an immune perspective, an immune modulatory perspective, and multiple downstream enzymatic inhibitors. I see a future where we start with mTOR inhibitors, we add on an AKT inhibitor, we add on something that works on PTEN, we try something that's a MEK inhibitor, we start crushing these pathways from multiple angles. It's why we haven't found like some of these diseases that we think we understand genetically, TS should be curable. Why is it that giving everolimus in kids with TS only results in a 60% reduction in their epilepsy and only results in stabilization of the subependymal giant cell astrocytomas? It just doesn't make any sense. We're giving an mTOR inhibitor in a disease where we know the gene that's affected, we know exactly what it does. Or NF. We have MEK inhibitors for NF. You guys have seen that's dramatic. That's completely changed my career. It used to be like early on when I started in neurosurgery, we were taking out all these schwannomas. Now we're giving them all, selumetinib. And yet we're still not curing them. We're still not taking those tumors away completely. And so there's just, I think to your point, there's more hope. Okay, yeah.
Introduce yourself if you need to know Dr. Hauptman.